of quick 15 minutes. Today's topic is on plasma cell neoplasm. So you all know, right? What are plasma cells? They are nothing but the mature B cells, right? Which will produce your immunoglobulins. So that you'll have a immunity. You will not get infected, correct? So now my question is, do plasma cells divide? Normally, no, correct? So what's making them to divide? That's why they are dividing. That's why they are giving rise to plasma cell neoplasms, right? So why your plasma cells are dividing? Okay, normally what plasma cells do? They produce the immunoglobulins, right? So what are immunoglobulins? They are a type of proteins, right? So every protein in our body is produced by a gene. So what gene produces this immunoglobulin? That is IgH gene, right? So which chromosome? Chromosome number 14, it is located. So what happens when this chromosome 14 will acquire abnormal translocations with another genes, which will give it some advantage to divide rapidly. Correct? Normally, it will not divide, right? So that's why it gets an additional benefits of excessive proliferation and it becomes malignant, right? It gets an advantage of growth and survival due to translocation between this chromosome 14, and it's very clear you can chromosome 14 with chromosome 4, 11, and your 14, correct? 16. So these are the three translocations which will happen with your chromosome number 14, which is on your, which will secrete your immunoglobulin, right? And it will get the additional benefits of getting mutated, excessive proliferation. Now, normally, whenever in your any cell, when you get these mutations, translocation is a type of a mutation. So what will happen? Your P53 will stop it, correct? And causes the DNA repair. If the cell won't repair, it will kill the cell by apoptosis. So what will happen in this malignancy is the cell is so intelligent. So there will be a deletion of your P53, deletion of your retinoblastoma gene, which is located on chromosome number 13. P53 is chromosome number 17. And CDKN2C and amplification of 1q gain. So all this will happen. That will give the additional advantage of to this plasma cells to divide uncontrollable and excessively. Since this is having a mutation, so whatever immunoglobulin it produces will be abnormal. So that's why you will be more, the patient who develop plasma cell neoplasm will be more prone for the infections. And this light chain, which is produced in excessive amount, it will be released in the blood, right? So it will go and deposit in the various organs, like in the kidney, it will cause cast nephropathy. In the liver and heart, it will cause amyloidosis. And this will increases or activates your osteoclast, leading to the bone resorption, leading to fracture and excessive serum calcium levels. Okay. And also this light chains will be circulating in your blood, right? So what is there in your blood vessels? You have an RBC. Normally RBC won't touch each other because they have the zeta potential that is called negative charge. So they repel each other, right? So this will go and deposit it on the surface. So this charge will get neutralized. That's why they sit on one above another. That is called Rayleigh formation. So now you understood the pathogenesis. You have a post-germinal center plasma cells, which are mature B cells. They will acquire this somatic hypermutations and the translocations with the chromosome 14 and 4, 11 and 16. And there will be deletion of P53, which is located on chromosome number 17, RB1 gene, which is located on chromosome number 13, and CDKN2 deletion and 1P gain. So because of this plasma cell become malignant and it starts proliferating in excessive amount and produces this non-functional immunoglobulin. So you will expose for more infections and this will cause activation of your osteoclast leading to bone resorption and fractures and increase serum calcium levels. And this immunoglobulin or the light chain gets deposited in the various organs leading to amyloidosis, and also it will deposit on your RBC surface leading to Rayleigh formation. Now, one more thing you have to understand is clonal plasma cell proliferation, right? For example, this plasma cell has acquired this mutation. So it will divide and forms the daughter cells which are clones of these cells, right? So normally a plasma cell can produce only one type of light chain, right? So either it will be kappa or it will be lambda. So for example, this cell which acquired the mutation, it produces only kappa, means all the daughter cells or the clones of this will produce only kappa, right? So that is called as light chain restriction. Right now you have a severe infection. So you have plasma cells, right? So there also plasma cells might divide, not like rapidly as in your plasma cell neoplasm. So this will produce kappa, this will produce lambda, right? So that means you will have their polyphenotypic light chains, right? So that you see in infections. Whereas in clonal, where there is a mutation, you see only one type of light chain. That is called light chain restriction. So this is very important to differentiate between infections and plasma cell neoplasms. Next, as I told you, so you have a lytic lesions, hypercalcemia, and this IgG is getting deposited in the kidney, causing renal failure, and is proliferating in your bone marrow and suppressing your erythropoiesis, leading to anemia. And you have non-functional immunoglobulins leading to infections. So when, like, see, as a clinician, we want some parameters to measure these things. So when anemia means when the hemoglobin is less than 10. See, always it's difficult to remember. So I need like this. See, remember this is 10 grams per deciliter. Then calcium more than, after 10 what you will get 11 milligrams per deciliter. If I join these two, it will be 2. So creatinine will be more than 2 milligram per deciliter. Then again 1. More than or 1 equal to bony lesion in our CT or PET. So if these parameters are there, you call it as myeloma defining event, on there is an end organ damage due to this clonal plasma cells proliferation. Remember. Then how does a normal plasma cell look? It will have an eccentrically placed nucleus with cartwheel-like nucleus, and there will be a perinuclear half. Why this perinuclear half we'll see means they are producing immunoglobulins. Immunoglobulin is a type of a protein. So they will not take up the stain. So that's why you see this clear area called as perinuclear half. Then you have binucleated plasma cells. You can have a plasma blast where you see this prominent nucleoli. And you can have these flame cells. Okay. Then Deshner bodies means, see, these plasma cells are clonal. They are malignant. So they will not produce a normal immunoglobulin, right? It is abnormal one. So it gets accumulated in the nucleus, leading to an inclusion called as Deshner bodies. The same inclusions get deposited in the cytoplasm. Then you call it as Russell bodies. If that entire cell is getting dilated and full studded with it, it is called as moth cells. Or sometimes you see this aura like crystals also. Okay. So these are the various morphologies you see in a plasma cell neoplasm. So in the bone marrow, you see the plasma cells. Normal plasma cells are 6 to 10%. So you should see more than 10% plasma cells. Then I told you why the Role will form. In peripheral smear, you see the Role formation. In the kidney, there will be deposition of this material, that immunoglobulins, right? So now, before going to the classification of plasma cell neoplasms, I want to tell you the difference between the previous WHO and the WHO 5th edition. So we have 10B, which I will tell you what is a full form. It was a provisional entity in the 4th edition. Now it is a subtype. Previously, the MGUS, that is monoclonal gammanopathy of undetermined significance, was placed under plasma cell neoplasms as a precursor lesion. Now it is removed and put it under monoclonal gammanopathies side heading. Okay. Third is ASOP is a new syndrome which was added. Okay, we will see now. So how does this 5th edition of WHO classifies the plasma cell neoplasm as a plasmacytoma, plasma cell myeloma, plasma cell neoplasm associated with paraneoplastic syndrome. So as you know, what is plasmacytoma? Oma means a single lesion. So it's a solitary lesion you should see. Clonal proliferation of plasma cells you should see, and you should not see any myeloma defining event. So what is myeloma defining events? Hemoglobin less than 10, serum calcium levels more than 11 milligram per deciliter, and serum creatinine more than 2 milligram per deciliter, more than or one bony lesion on CT or PET-CT. There are two types of plasmacytoma. Like if it is occurring in the bone, right? You call it as solitary, correct? Usually plasma cell myelomas or plasma cell neoplasms occurs in an elderly age group. In an elderly age group, which bone is active? It is axial skeleton, right? Like spine. So that's why it's common there. Extramedullary means it is not occurring in the bone. So where does it occur? The common is head and neck, like upper respiratory tract, PNS, and nasal cavity. So this was about your plasmacytoma. Then comes to plasma cell myeloma. So when to use the term plasma cell myeloma? When to use the term multiple myeloma? So the difference is plasma cell myeloma, I just got a bone marrow aspirate or biopsy. I don't know the clinical history, context, anything. That time I will use the term plasma cell myeloma. If I have the clinical parameters like the myeloma defining events, I have the serum calcium levels, hemoglobin, creatinine, I have the CT, then I will call it, along with that my bone marrow is showing plasma cells more than 10% or 60%, I will call it as multiple myeloma. So what is the criteria for this? So in the bone marrow, at least you should see more than or 10% of clonal plasma cells, and you should see the myeloma defining events. Or you can see in the bone marrow more than 60% of plasma cells, right? Or you can see the serum free light chains more than 100 milligram per deciliter, or you can see more than one lytic bony lesion, which is more than 5 mm. Okay, so this is a criteria. Then again, this plasma cell myeloma is divided into smoldering multiple myeloma, non-secretory myeloma, and plasma cell leukemia. So plasma cell leukemia means there is more than or equal to 5% of plasma cells you see in a peripheral blood. Non-secretory means there is no active secretion of your immunoglobulins. So that's why when you do a serum or a urine test, you will not see a M protein. M protein is nothing but that abnormal immunoglobulins which are secreted by your plasma cells. Smoldering means asymptomatic. So it will have, the bone marrow will be showing the plasma cells somewhere around 10 to 60% in between, but you will not see any myeloma defining agents. Events like hemoglobin, all those things won't be there. Along with that, you should see a monoclonal proteins in the serum, okay, which will be more than or equal to 3 gram per deciliter or more than 500 milligram for 24 hours. But you will not see any myeloma defining events. That's why it is called as smoldering. Smoldering means asymptomatic. Next is your plasma cell neoplasms associated with paraneoplastic syndrome. So you have three syndromes. One is POEMS, one is TEMPI, one is ASOP. So what do you mean by POEMS? Means P stands for polyneuropathy, O for organomegaly, E for endocrinopathy, M for monoclonal gammonopathy, S for skin change. Next is your TEMPI. T stands for telangiectasia, elevated EPO erythropoietin or erythrocytosis, monoclonal gammonopathy, perinephric fluid collection, and intrapulmonary shunting. ASOP means it is a newly added entity. You have adenopathy, extensive skin, E stands for extensive skin patch overlying plasmacytoma. It's a skin patch overlying plasmacytoma. So these are the three paraneoplastic syndromes associated with plasma cell neoplasms. So thank you.